Morning, everyone. I apologize for not being able to come in person today. Unfortunately, I took a COVID test last night and came back positive. So I'll be conducting my presentation via remote today. And with that, let's get started. So my article was about portable low-field magnetic resonance imaging enables highly accessible and dynamic bedside evaluation of ischemic stroke. So there's a general introduction about the article. Stroke is a leading cause of disability and death affecting 15 million people worldwide each year. And non-contrast computed tomography and magnetic resonance imaging are commonly used for evaluation of strokes, but MRI has been shown to be superior. And the reason for that is due to its high resolution and multimodal imaging. So therefore, there's been a surge of research done for portable imaging, just because it's less costly and it's also more efficient for point of care alternatives. And traditional imaging pathways usually include the patients being transported from controlled clinical environments to remote radiologic suites with the imaging technologies. Thus, the transport itself includes both cardiovascular and respiratory risk, and sometimes even delays that are detrimental to the critical ill patients. Therefore, by having devices that be able to bring into the patient's rooms themselves and take it there will be a lot more efficient and a lot more beneficial to their patient health outcomes. So one of the devices that's already been used is PCT, or portable computed tomography. And what this is it's a portable imaging modality that's already used in tertiary and quaternary health care centers to image patients with acute brain injuries. And some of the detriments of why this might not be as feasible is that it still requires lead shielding and specialized technicians for proper operation, as well as there's an associated risk of ionizing radiation from both patients and the PCT operator, and also just the images themselves. MRIs, like I said before, they have high quality resolution, while X-rays are usually limited in detecting acute ischemia. Therefore, you would want to create a device that replicates the images produced from the MRI, which leads me to the portable MRI. So we had some questions regarding what it might look like and the size comparison compared to the conventional MRI. So it is a lot smaller. It's also able to, it doesn't require its own room. So I think the article mentioned that the height is about 140 centimeters and the width is about 86 centimeters. For me, it's a little better to look at the next picture, which I'll show in a second, regarding how when it's being used to really show the size comparison. And then we also had some questions regarding the different sequences being produced. So these different sequences are, all in all, they affect the radio frequency pulses and gradients, which then result in the different images obtained by the MRI. So it seems that both the T1 and T2 weighted sequences are the most common protocols for MRI images, allowing identification of tissues and anatomical structures with ease. Meanwhile, the FLAIR, or the fluid attenuated inversion recovery, is a form of imaging in which the brain suppresses the cerebral spinal fluid, or the CSF, in images due to its high signal in other protocols. And therefore, this method is usually used when trying to look at the brain volume and abnormal increases in it due to fluid within the brain. And lastly, DWI incorporates both the diffusion values of water molecules moving through the tissues with the T2 protocol for a relatively low resolution image of the brain. And I believe the article also mentioned ADC, or apparent diffusion coefficient maps, which are taken from the DWI images, and they show the diffusion values without the T2 effects. And these are also usually low resolution images as well. And some other questions. We had one about the actual price itself. So in regards to the nominal cost, I looked at some other articles and it said the nominal cost of the MRI is usually about $1 million per Tesla, with most MRIs being about 1.5 to 3 Tesla. So given this amount, the portable MRI machine will cost about $64,000, which in my opinion is still a lot of money. But I guess when you compare it to the conventional MRI, and given the other benefits as well, especially the ease of use and accessibility, healthcare organizations and hospitals be more inclined to buy more of these portable devices. And then I think we had one more question regarding the how the images will be how the images will look given the low field technology. So this device has actually been used in other studies as well by the same team. So it seems that based on the other studies I looked at, the electromagnetic scanners have been optimized to produce images with the short acquisition time, or relatively short acquisition time, with the 25 minutes, usually for each for the total scan to take, and a high signal to noise ratio, excuse me. So of course, high field MRI is known as the gold standard. But given the circumstances of trying to identify these life-threatening conditions for these patients who might not be able to get to these radiologic suites, it seems that these images are comparable to the conventional MRI. And just another tidbit I found was that these images are acquired without pre-polarization techniques at a fixed magnetic field with a simple, the old machine was a simple single channel inductive detector. This one's actually 8 channels, as well as it has a biplanar 3-axis gradient. And also the machine is able to integrate electromagnetic interference rejection within the device to remove the need for the shielded room, which I assume is the little coating on the outside of the head scanner. All right, and then once the images are taken, they're uploaded to a connected iPad, which shows the images in real time and could be uploaded to another cloud-based server after that. All right, and then so just the overview of the study itself. The article says it's a systematic evaluation of pMRI for imaging cerebral infarction and its clinical utility in the management of ischemic stroke. As it also includes patients with ischemic stroke in 3 units within the hospital. And I'm going to go over the criteria for that in the next slide. And some of the findings that were included from the article is that pMRI was able to detect ischemic. pMRI was able to detect ischemic infarcts and detect smaller lesions, as well as it was able to provide a first-line diagnostic imaging and serial neurological monitoring for critically ill patients, as well as the ischemic infarct volume measurements were consistent between low field pMRI and conventional high field MRI exams. Another finding was that there's low field pMRI stroke volumes were significantly correlated with stroke severity at the time of exam and functional outcome at discharge. I'm going to go over this in the next few slides with the figures and the tables. And so these images, patients were first imaged with a, I just want to note that, patients were first imaged with the standard of care imaging techniques, which were the NCCT or the 1.5 or 3 Tesla MRI, to confirm the presence of cerebral infarction and localized lesions. Then the pMRI was conducted within 36 hours of the exam using the standard technique as reference points. So the pMRI was considered to have correctly captured infarct in at least one sequence. If at least one sequence is able to detect the known infarct or where the stroke was occurring. And those that correctly identified the lesion were involved in further volumetric analysis, in which lab members determined the infarct volume measurements from both the pMRI and the closest CMRI conducted, and then performed the statistical analysis, which are these measurements down here. All right, and going back to the picture. So as you can see, it is a lot smaller than the conventional MRI, and with the shielding, it prevents it from disrupting the other devices that are in the room, such as the IV pumps and the vital sign monitors and stuff like that. All right, so the study itself was conducted in July 2019 to December 2020, so relatively recent, in the NICU, ED, and COVID-19 ICU of Yale New Haven Hospital. And the inclusion criteria is that patients in the NICU are, if they have a standard of care NCCT or MRI exam that includes indicates that they have a neuropathologic disease or problem going on. Patients in the ED, it's if they have a suspected diagnosis of stroke, I'm assuming based on the symptoms they present. And patients in the COVID-19 ICU, if they demonstrate or suspect neurological deficit. So some exclusion criteria is the inability to lay flat, patient body habitus if it exceeds the dimensions of the portable MRI, or the presence of MRI contraindications, such as if you have any cardiac pacemakers or insulin pumps. And the study evaluated only patients with a clinical diagnosis of ischemic stroke as confirmed by the standard of care neuroimaging, which I mentioned before. I think I had a question regarding kind of like what's the use of a portable MRI machine if you still need to use the conventional MRI? I think in this case, it was just as a comparison. I assume that later studies, unfortunately, I didn't see much about it in the readings, but I assume that future studies during these critical situations, you would not need to utilize the conventional MRI machines as much, or maybe at a later point when the patient is in a more stable condition after using the portable MRI machines. All right, so then just go over the results of the article or the study. About 50 patients with ischemic stroke had intracranial imaging obtained with low field MRI. These are just the characteristics of the patients on the right that were included in the study. About 58 low field pMRI exams were obtained at an average of 37 plus 60, that's standard deviation, hours after a patient's last known normal time. So within that time, there would be the standard imaging taken. So pretty much the NCCT or the standard MRI images would be taken from them, and then the portable MRI machine would be used after. And the protocol included T2W, FLAIR, and DWI sequences, as well as all of these were performed, as mentioned before, in the presence of ferromagnetic materials. So, and also the sequences did include the apparent diffusion coefficient. Just want to mention that. And I said this before, but the exact time for conducting the study was about 25 minutes using the pMRI. All right, so figure 1 shows you some images produced from the machine for some of the different patients that were included. So all in all, about 45 out of the 50 patients included in the study, the pMRI was able to detect the ischemic infarcts with a sequence-specific sensitivity of 98% for T2W, 100% for FLAIR, and 86% for DWI. As you can see here, the infarcts are shown as regions of hypersensitivity in T2W, FLAIR, and DWI. So this is the infarct over here. I'm not sure if you can see my cursor, but I certainly hope so. The infarcts are the kind of the lighted up regions in these three, while the ADC it shows a reduced region. In other words, it's just a darkened region. And that's for both. That's for patient A and patient B. It's over here. And patient C, it is over here. All right. And then figure 2, it shows that it shows patients with ischemic stroke with infarcts that were not visualized by the pMRI. So there were 5 patients in which the infarcts were only detected from the high field MRI DWI sequences. One was due to patient movement, while 4 others were the 4 others, which are seen here, were interpretable, but you cannot actually see the infarct on these images. So therefore that's one of the limitations of the machine. And so I think someone had a question regarding the foci of restricted diffusion. Pretty much, yeah. It is a limitation of using pMRI in that it can not all infarcts were detected. And let's see here. This impacts the effectiveness of pMRI most certainly. It seems that there might be some more optimization that was required in order to detect these lesions, given that they are greater than 4 millimeters, which was kind of the range that they wanted to get from this machine in terms of identifying infarcts in that size range. All right, and then figure 3. Figure 3 shows the ischemic infarcts of various lesions shown, various lesion sizes shown on the pMRI. So the article referenced this image to show that ischemic lesions were detectable in all brain regions, including the anterior cerebral, middle cerebral, and posterior cerebral, as well as cerebellar arteries and watershed zones. In other words, just the different locations that you could see these infarcts. Oh, excuse me, over here. And then, while the majority of patients included were from the NICU, the article mentioned that 2 patients from the COVID-19 unit actually were an unknown stroke was detected with the pMRI used as a first-line diagnostic tool. Therefore, their care was changed, or they had confirmatory neuroimaging studies, and then their care was changed after those studies confirmed the presence of a stroke. So unfortunately, I wasn't able to find much about the confirmatory neuroimaging studies. My initial guess was that they were going to give them the MRI or the NCCT, but I think it also mentioned that it might have been clinically unfeasible to do that initially. This is before they used the pMRI. So I'm also wondering if they kind of went over that and they decided to give them those types of imaging modalities, or if they use maybe a portable CT. Unfortunately, I'm not sure about the answer, but I certainly can try and look more into that as well. And then in figure 4, so figure 4 was just showing that you can use the portable MRI for different imaging points or different timestamps. And it shows in this image the evolution and extension of acute ischemic infarction from the cerebellum into the brainstem. So you can see here that's kind of, oh, there we go. It's kind of, yeah, based on the images, you can see that it's moving from different areas in the brain, essentially. All right, and then figure 5, it shows that it shows 2 patients who receive high field MRI exams that showed restricted diffusion on DWI, but not on T2W or flare. So you can see here is DWI, but these two, it's not really seen here. It's kind of hard to see, if anything. So therefore, the figure was just showing that the results are correlated with the pMRI and demonstrate interval development of the hyperintensity on T2W and flare sequences, also down here as well. I think it might be up here. I know it's kind of hard to see. And then, so the next figure is about, so after these images were taken, 2 lab members, they measured infarct volumes on T2W and flare and DWI sequences as well for each pMRI exam. And if available, they also compared the conventional MRI exam that was acquired within 36 hours of the pMRI exam. So 37 of those patients had the CMRI within the listed time frame. 16 were actually, so 16 actually had their pMRIs conducted before the CMRI. Sorry, I forgot to mention that before. So they did, some patients did have the CMRIs taken before the conventional, while others, about 21 patients had the CMRIs taken after, or portable MRI taken after the CMRI. So I want to backtrack on that. And then, so figure 6, it kind of shows that for anyone who's done a bland Altman plot, unfortunately, I've never done one myself, but given the data in the information in the article, as well as just some outside research, it shows that there's significant agreements between the pMRI T2W and the flare sequences. Pretty much that the volumetric measurements between the both measures, imaging techniques are related and are in agreement with each other, while B, C, and D show that the pMRI infarct volumes were strongly correlated with the volumetric measurements taken from the conventional MRI for these sequences. And this figure 7 shows how the infarct volumes that were taken are significantly correlated with the stroke severity at the time of the pMRI scan, as well as functional outcome at discharge. And what that means is, so figure 7C, patients with poor functional outcomes, they usually had larger infarct volumes measured on all of the either T2W, flare, or DWI images. And this one for those of you who might have done a binary logistic regression analysis, and once again, I have not done not done much about it, but it looks like the data was conducted to evaluate the relationship between the pMRI stroke volume and the discharge functional outcome. So for unadjusted indicated volumes, these were significantly correlated with functional outcome for the 3 different sequences, while the multivariable adjusted model was adjusted for baseline prognostic values, and it was only indicated for T2W and flare, which were significantly associated, but not DWI. All right, so that was a lot of information. All in all, based on the discussion, the researchers were able to deploy a highly mobile 0.64 Tesla pMRI scanner into inpatient and emergency care settings, and they're able to accurately demonstrate and characterize ischemic stroke at the bedside. These include able to detect lesions in various parts of the brain, as well as have stroke volume measurements that are consistent across the pMRI sequences taken, as well as having those sequences consistent with the CMRIs. And last but not least, the low field pMRI stroke volume measurements were significantly correlated with stroke severity. So, sorry, I had a burp. Excuse me. One of the things about the machine is that it's able to provide neural imaging without the challenge of transporting patients to radiologic suites. Given that it's pretty much serial imaging overcomes the challenge of having to transport the patient to radiology suite at various times, which provide risks to the patient's health outcome, as I mentioned before. Therefore, you allow the monitoring of the progression of the stroke and assess the efficacy of treatments. It's also just affordable, or relatively affordable, due to the reduced cost of manufacturing, maintenance, and operation, as well as it includes the electromagnetic interference rejection, which overcomes the needs of a radiologic suite and does not require specialized technicians, given its ease of use. And I think we had a question regarding about, is there a clinical concern about being unable to detect less than 4 millimeter lesions? I believe the answer is yes. I'm not too sure to be too sure about that, since it seems that most of the lesions that were shown here are above 4 millimeters, but I assume that you would want to optimize the portable MRI to detect any kind of lesion. That's just my intuition. Maybe the professor might have some of his own as well. And yeah, so we covered all that here. And just some limitations and future research. That goes back to the 4 millimeter lesions. Unsure if it's able to detect anything smaller than that, but that's certainly a limitation in itself. And one of the other things that the signal to noise ratio for the DWI sequences is much lower compared to the T2W and flare sequences. This is due to the long diffusion preparation gradients, as well as the low magnetic field. And therefore, the researchers were unable to detect the sensitivity of pMRI DWI. So therefore, a recommendation was to further study and optimize the pMRI DWI, as well as develop and implement imaging techniques, such as deep learning algorithms. And some other limitations include possible bias from not including blind reviewers for analysis of the study. So they recommend future blind radar analysis to further delineate diagnostic capabilities. And lastly, MRI requirements exclude patients with cardiovascular implants, as well as the other criteria listed before. So therefore, low magnetic field MRI, there's been research showing that those with cardiovascular implants can actually use MRIs. Therefore, one of the other outlets that future research can provide is utilizing this low field MRI for these patients. And I believe we also have some other questions regarding, oh yes, if it's being used in other areas, both around the world and in the US. So I looked it up, and some other universities are doing research as well, are using the devices for research as well. UC Davis and Ohio State University have both started doing trials with it, as well as another article I actually read was about the Medical University of South Carolina has been conducting trials with the MRI in the back of an ambulance which I believe is interesting since the back of an ambulance after working as an EMT, it's already small enough. But if it does improve patient outcomes, most certainly you can go for that outlet as well. And even in Canada, they've also been using the device or bringing it there to provide medical services to Indigenous populations in the Winnebago Area Health Authority. And that's in Northern Ontario, as well as there was another article from UConn saying how there's a clinical researcher at UConn who goes on trips funded by the Melinda Gates Foundation to India, Zambia, South Africa, and Uganda to train doctors there to use portable MRI scanners. So it looks like it's already being used in low resource settings as well. Another question we had was, can the pMRI be used to image parts of the body besides the brain? Unfortunately, there's not much done on this device itself. I did find the article, not too sure how accurate this might be, but it's from Magnetic Resonance and Medical Sciences regarding how a team of researchers in Japan are actually using portable MRIs, incorporating it into vans to obtain images of the wrist for sports-related injuries. I think it's more so related to tennis-related injuries. That was kind of what the article pictures and information was giving. So it seems that there's other types of devices being created for different uses, but I think for this one itself, the Hyperfine device is more so just for, brain-related neurological injuries, or especially just ischemic strokes. And I believe that might be all the questions we received. With that, if you have any other questions, comments, or concerns, I apologize I can't come in there in person. But I appreciate everyone for the time and hope you have a great rest of the day. Thank you.